Anyway, it is my pleasure to now introduce the younger sister of Eleni Andreopoulou, Dr. Panagiota Andreopoulou, better known as Penny. Dr. Andreopoulou received her medical degree at the National University of Athens Medical School in Greece. Following her residency in internal medicine at New York Hospital of Queens Weill Cornell Medical Center, Dr. Andreopoulou completed her endocrinology fellowship at the National Institute of Health in Bethesda, Maryland. She conducted clinical research at the Skeletal Clinical Studies Unit of the Craniofacial and Skeletal Diseases branch and has published the results in peer-reviewed journals. Dr. Andreopoulou practices general endocrinology with a special focus on osteoporosis and bone health. She's a member of the American Society for Bone and Mineral Research, the Endocrine Society, the American Association of Clinical Endocrinologists, the American College of Physicians, and the American Medical Women's Association. In addition, she has multiple activities aiming to increase awareness in the community about osteoporosis prevention, diagnosis and treatment and preservation of bone health as well. She gives community seminars at HSS and produces and hosts a weekly radio broadcast in Greek at the Hellenic Public Radio on health and wellness issues. She is a vice president of the Hellenic Medical Society of New York and thus organizes the Society's educational symposia and provides mentorship to younger colleagues of Greek origin. I now welcome Dr. Panagiota.
Thank you, Froso. Your Eminence and members and friends of the leadership, it is really, I'm very deeply honored. It's such a great honor to join my sister Eleni in addressing this forum today. Thank you so much for the invitation. I have to say that Eleni and I share the values stemming from our Hellenic culture and our Orthodox faith that are indeed deeply intertwined, and her speech deeply moved me. We grew up in Greece, but we returned to America as the latest chapter in a family story of perpetual return home. So we have a very unique migration story, starting from our paternal grandfather, who arrived in the shores of America more than 100 years ago. He was a successful businessman, and then he returned to Greece to raise a family. And then our father came in the early 1950s. He left a war-torn Greece to come here, following his father's steps in a golden age America of the 50s. This is how he described it. And then he returned to Greece to raise his family. And we came back in the dawn of the 21st century. So we keep going home. And home for our family is both Greece, where we have very deep roots. We're very proud of our Hellenic heritage and of our faith. We have very deep roots in a blessed country. It's blessed in any way with amazing beauty. And the only thing it lacks, I think, is leadership. But home also for us is here, America. And we really value being a part of the Greek diaspora, of the Hellenic diaspora. We're very honored to be among such accomplished members of it today. And we also believe that everything we do in our professional life and our personal life really reflects upon the diaspora and reflects upon the Greeks of Greece. So it's really a major responsibility for us to be here today. And thank you so much. So we also share another passion, not just Hellenic heritage and Orthodox faith, but our other passion we share with Eleni is medicine. We're inspired by the complexity, the beauty, and the wonder of God's most divine and sacred gift, which is human life and the human body. And when I was a medical student in the University of Athens, I really wanted to become an endocrinologist. I chose that very early on, because I realized that the body has a fascinating, highly complicated, and highly intelligent messenger system that dwarfs any supercomputer the human mind has created thus far. It's an amazing, amazing creation, and by getting to know all these pathways, a lot of them are hormonal pathways, hence endocrinology, our faith in God is even more reinforced. What he has created is phenomenal. So I really wanted to study this discipline, endocrinology. And when I went to the NIH, I realized that a major component of that information system is actually active in our skeleton, our bones. It's an organ that a lot of us think that it's just a hard and lifeless structure that just keeps us together. Well, actually, it's an organ that's very alive, it's very dynamic. It's consisting of cells that vibrantly interact with one another as well as with other organ systems in our body. And our skeletons and our bones are often afflicted by a silent disease, osteoporosis, that may manifest with irreversible and often devastating events that are fractures. So I diagnose and treat osteoporosis every day, and we have very powerful, very strong agents in our disposition today to try to prevent fractures and to try to strengthen the bone. Some of them also try to improve the bone structure, although we're not at that level yet. And this is great. I am a healer in that sense. I do prescribe therapy, and all physicians are healers, but we're also proponents of disease prevention and educators. We educate our colleagues, we educate our patients every day, and we educate our community. So I wanted to grasp this opportunity to spread awareness for a common but often unrecognized health problem. And I won't be able to show you something comparable to Angelina Jolie. So I don't think a woman who fractured will make the cover of Time magazine, but it is a very common and very important health problem. So this is bone. The figure on the left is a healthy bone. It's normal. It has intact microarchitecture, and that renders it capable of withstanding loading forces of very different directions every single minute of our life. And the one right to it is the osteoporotic bone. It's a degraded bone, and it's fragile, and that's where the word osteoporosis comes from. Osto, bone, and poros, which is a hole. So you can clearly see those in the degraded bone. Another Greek word that has survived in medicine. So what is osteoporosis? It's a skeletal disorder. It's characterized by compromised bone strength and predisposes to increased risk of fracture. And bone strength reflects the integration of two main features. One is bone density, which we can easily measure with a very simple test, which is called a bone density, a DEXA scan, that we use to screen for osteoporosis. It's just a plain x-ray of the spine, the proximal femur, the hip, and sometimes the wrist. And bone quality. And bone quality is something very challenging for us clinicians. We have research ways of trying to assess it, but we haven't been able yet to define it, to define normal reference ranges and be able to assess this. So it's a big unknown for us, and there's a lot of research going on in this section. But osteoporosis is a serious public health problem. These are data from the U.S. Surgeon General report from 2004. So this is 10 years ago, and I can imagine that now the problem is even bigger. But by that data, osteoporosis affects 10 million Americans over the age of 50, and 80% of them are women. But it is also a men's disease. It's not just a women's disease, just men get it usually a little later, about 10 years later. There are 2 million fractures yearly that are related to osteoporosis. These are not fractures that have to do with car accidents, high-impact fractures, sports, skiing, or so on. These are fragility fractures, fractures that happen just by fall from standing height. You're walking, you fall, you fracture. And what's very interesting is that 1 in 2 women over the age of 50 is going to suffer a fragility fracture, a low-impact fracture, and 1 in 5 men. So it's a highly common disease. And unfortunately, less than 50% of patients that fracture will return to their full pre-fracture function. The will have some type of debilitation. A hip fracture may never get you away from needing a walker to walk. You may not be able to walk again just with your cane or without any assistance. Another important thing is that a fracture that happens denotes fragility. So this person is really very high risk to fracture again. So it's very concerning. And we really don't want to get there. We really want to prevent a fracture from happening. And fractures can happen anywhere. More common are the vertebral fractures in our spine. Very worrisome is that 2 out of 3 of them are silent. So you may have a fracture in your spine and you don't know it. A peak age for that in women is the 60s, their 60s, in men is their 70s. And you notice that you're shrinking or that your posture is changing. And okay, you don't have any pain, but what's important is that even silent fractures increase your risk for other fractures anywhere in your body, vertebral or other bones, by 4 to 5 times. And multiple vertebral fractures may eventually cause debilitation, they might cause pain, restrictive lung disease. So these are very important. Other fractures are wrist fractures, quite common in women in their 50s, hip fractures that start in the 70s, pelvic fractures that are can be very painful, and other fractures in the body. And I want to point out that 10 years ago, the direct cost of treating fragility fractures was $17 billion, which I think can be used in a different way if we prevent these fractures. Maybe funnel them towards research for cancer or other diseases, as we talked about, or for other goals of our society. So it's so sad to have such a high cost, personal cost, individual for patients, and cost for our society and our public health system for a preventative disease, a disease that we can prevent. So it's very common. 34 million Americans have low bone mass. It's the same as the 36 million Americans who have uncontrolled high blood pressure, and a little less than 48 million Americans with uncontrolled high cholesterol, bad cholesterol. So it's a very common disease, and it's a silent disease like the other 2. And we do have effective means of treating it and preventing fractures that are much more effective than blood pressure medications are for preventing heart attacks. So why not diagnose it early and treat it? And I want to point out that the lifetime risk of fractures, of osteoporosis in women over at the age of 50 is 50% for fractures and 12% for breast cancer. So breast cancer is a very common disease, with fractures are even much more common. And for men, the lifetime risk at age of 50 of prostate cancer is 17%, and for fractures, 20%. It's a very, very common problem. And the type of fractures, now this looks a little complicated, but what I want to drive home is that the type of fractures differs per age. The more we age, the more our risk increases. Our bones are older. They're subjected to a lot of inflammation and oxidative stress over the years, hormonal changes. So they're more susceptible to fractures. Women start fracturing in their 50s, their wrist, in their 60s, their vertebra, their spine, and in their 70s, their hip. And men start about 10 years later. But it's also a disease of men as well. And I just wanted to show what a spinal fracture looks like, a vertebral fracture where the little arrow is. That cannot be reversed. Once this happens, it's going to stay like this. We cannot make a vertebra the way it used to be. So we'd rather prevent this. And how can we know that we have osteoporosis? Well, it's a very simple test we can do. It's called a bone density, where it evaluates the bone density. It's a simple x-ray, really, of our lower lumbar spine, the first 4 lumbar vertebrae, and the hip. This is the proximal femur. This is our hip joint and the wrist in some centers. Very low radiation. It's less than the flight you took to come to Florida, to Orlando. Very simple test and and it has bone density it's reflective of fracture risk, has high correlation. So who should have a bone density test? Per the most conservative guidelines, women age 65 and older and men age 70 and older should have a bone density test. But also younger postmenopausal women and men ages 50 to 69 with clinical risk factors, and a lot of us have clinical risk factors. Might be illnesses we have, medications we're taking, a family history, a parent who fell and fractured a hip, that shows strong genetic history. Any adult who has a fracture after age 50 should be screened with a bone density, and of course adults that, as I mentioned, take medications such as proton pump inhibitors for their heartburn, very commonly used, steroids in patients with rheumatoid arthritis, asthma, skin diseases, antidepressants, tricyclic antidepressants, SSRIs, very notorious for affecting bone quality. So all these patients should be screened actually earlier. And I wanted to focus a little more on prevention because this is our goal. We don't really want to get there. We want to prevent bone loss, or we want to just stop it or delay it. And there's a lot of things that we can do as patients before we actually have to take treatment. First of all is our diet. We have to eat a diet rich in fruits and vegetables, and if supplemented if necessary, in order to get the appropriate amount of calcium. So it should be about 1,000 milligrams per day for men 50 to 70, 1,200 milligrams for women over 51, and 1,200 milligrams per day for men over 71. And the richest source of calcium is dairy. And it can be non-fat or low-fat. It doesn't have to be the full-fat dairy. So that's the richest source. Green vegetables as well. These are very important. And then our vitamin D intake should be 800 to 1,000 units per day. And it could be supplemented if necessary, and it is necessary. Unfortunately, vitamin D is a hormone that we compose on our skin with sunlight exposure. We need about 5 to 10 minutes a day of exposure of our arms and legs in the sun without sunscreen to make a good amount of vitamin D. But unfortunately, in most of the latitudes we live in, we don't really make any during the winter time. I can reassure you, in New York, you make zero. And even in the summertime, we wear sunscreen, and sunscreen reduces vitamin D composition by more than 95%. So all of us should be taking a vitamin D supplement, and usually it's 800 to 1,000 units a day. Regular weight-bearing and muscle strengthening exercise is very important, and I really want to stress this. We should all be doing weight-bearing and muscle strengthening exercises. And what are weight-bearing exercises? It's exercises that make you move against gravity while staying upright and just standing. And it's recommended that we do 30 minutes of weight-bearing exercise every day. And it can be high-impact exercise for a lot of us, such as dancing or high-impact aerobics or hiking or jogging, running, jumping rope, stair climbing, or playing tennis. Although if someone is already fractured or is too frail, maybe they would like to do more of a low-impact weight-bearing exercises that are equally effective, such as using the elliptical or doing low-impact aerobics, the stair-step machines, fast walking on the treadmill or outside. New Yorkers walk a lot, by the way. Weight or other resistance against gravity. And you can do that 2 to 3 times per week with lifting weights or using the elastic bands, the weight machines, or even standing and rising up on your toes, up and down. That's actually muscle strengthening exercise. Yoga and Pilates, although some of those movements might predispose in spinal problems, like the torquing, twisting, spinal exercises are not recommended, or a lot of the bending. But they help with strength, increasing strength, balance, and flexibility. Non-impact exercises that are helpful for balance, posture, and they affect how well you move. Like Tai Chi at the HSS Hospital for Special Surgery, we send all patients to do Tai Chi. It's actually very good for balance. And I always tell my patient, if some activity is the difficult to do, the one that bothers you, I have trouble, I feel stiffness getting out of bed, getting out of a seated position, just do that as an exercise. because this will help you learn how to do it better. And very important is fall prevention, evaluation and training, and avoiding smoking and limiting alcohol. A lot of these habits start with childhood, so even our children have to learn to adopt these habits that will help them build strong bones and maintain these habits for life, and thus their bone health for life. And this graph here shows exactly that. We can see that the upper graph is girls that drink their milk and girls that didn't, and the ones that do, they actually have a better bone mineral content, better bone density. And then the lower graph is older adults that drink their milk and the ones that don't. So the upper line is milk drinkers, and they do maintain a better bone mineral content. So it's important to start early at the time that we build our bones. And then fall prevention is highly important. To have a home that we can move in without being at risk for falling, like improve our lighting, remove our loose rugs, or put the grab bars near bathtubs or our stairways going up and down. Physical therapy, again, for core strength and balance. Medications, every time we go to our doctor, we can discuss, is this something I need? Can I just cut down on the 20 medications that I take every day? It's important. A lot of times we physicians prescribe medications and we forget to discontinue them. And assistive device evaluation and trainings, but some people may need a walker or a cane. And I just want to, again, focus a little on the diet measures. Apart from dairy, fatty fish varieties are important because they contain vitamin D, such as salmon, mackerel, tuna, and sardines. Lots of green vegetables. Fortified foods have vitamin D. And possibly olive oil. There's some new data out that olive oil may actually be helpful in preventing bone loss. So that blessed product of grease seems to just be a wonder product for everything, including osteoporosis. So we should definitely avoid meat and salty foods. Not good for our bones. Green vegetables that are high in oxalates, like spinach, also reduce calcium absorption. Wheat bran, legumes, they also reduce calcium absorption. And excess alcohol, too much alcohol, or caffeine, teas, coffee, sodas that have caffeine, so these are also not recommended. And this is how you can make vitamin D if you don't want to take a supplement. So, and that's very important because it's very common. Vitamin D deficiency is just so common. This graph shows the prevalence of low vitamin D levels in a minimal trauma fracture population. So these were 78 patients with hip fractures that are very, very debilitating. And 97.4% of patients, it's the bar on the far right, had a level less than 30. So it's just so universal. So next time you go to Greece, this is what you have to do. That's good for your bones. So thank you so much again for your attention.